You look at a computer, you probably go, I'll never understand it. You just push the buttons and hope the stuff works. A lot of people outside of medicine feel the same way. If you're not in medicine, a lot of it doesn't make sense. You need someone to help you. Otherwise, you're just pushing any button you can and hoping that something happens.
Health systems in general are very fragmented. But when you're in a health system where your payer is siloed out, your hospital is siloed, your primary is siloed, your pharmacy is siloed, your radiology is siloed, your lab is siloed, who is ultimately responsible for all of your care?
Care management actually becomes that human connection between what are, the formal healthcare service, facility-based kind of healthcare services, and what actually is going on in the context of patients' lives.
We have a lot of patients who don't engage with their primary care. We have a lot of patients who will use the emergency department as their primary care. So when these patients go into the hospital, we're alerted to make sure we catch them in that net, link them to their primary care, link them to any services they need in the community, and then just kind of be a support for them. Tony Robinson had severe asthma. It seemed like every week he was either in the emergency department or in the hospital. He started talking about how he doesn't have much of a life. And it's to the point now where everybody knows my name, and I said, yeah, Tony, because you're going every week. And I think that impacted him. That made him feel like being in the hospital constantly is not a life that I want for myself. What's your routine so you can keep your asthma under control?
When it come on, I just go ahead and take a treatment right then, or use my hand pump.
Right. The end of this month, I think it will make 3 months he's not been hospitalized, 4 months that he's not been to the emergency department.
Our care managers really can get into patients' lives, understand the context of their lives, and perhaps most importantly, help the patient to build the self-efficacy around decision-making, around healthcare access, and how to advocate for themselves.
The biggest thing I'm out there doing is teaching patients, teaching them about their meds, their bodies, their diagnosis, how they got to this point, and how they can get out of wherever they are.
But when they first started coming, we had 1 or 2 sessions with you lying on the couch, remember? Yeah, well, he didn't even get up off of the couch.
I never had paid attention. The higher my sugar was, the more pain my feet would be in.
She gave us a little plate with the sections where you have lots of vegetables, little bit of starch, and your protein. Now we're on a different path where we know it doesn't have to be dialysis. It's not that the diabetes controls us, we're learning to control the diabetes.
It's not every day that you get to have a nurse or a registered dietitian or a social worker or a pharmacy technician to come in your house and talk with you directly about anything you want. So I think that's one of the biggest opportunities that we provide to patients in the community, is that they have direct access to the healthcare system.
It's a proactive approach to care. If a patient does show up in the emergency department or is admitted to the hospital, we also know that immediately. More often than not, we're building the system so that we're not meeting them at that door. We're meeting them well before something like that would happen. In fact, let's hope we can prevent, something like that from happening.
The greatest success to me about this whole process is that instead of everybody working in their own little section of the world, only on their part, they're looking at the whole patient. If at the end of the day, you say, is this the best thing for the patient? And the answer is yes, just go do it. Isn't that what it's about?